Okay, so next up we're going to talk about the degree of injury. The easiest one to remember is a complete cord lesion. So that just means that the cord gets completely disrupted. It's either sliced apart, you've completely smashed it, that at whatever area of injury you've lost all or complete loss of the spinal column. Alright, so they have no sensory or motor function below the level of the injury any longer. A complete incomplete cord lesion is where they have a mixed loss. So some of the nerve tracts and the spinal cord are still intact. So they end up with a mix where they have some motor loss and some sensory loss. And it depends on which parts of the spinal cord are injured. So you can have central cord, right? This is most common with cervical injuries. Brown's cord is where you have damage to one half of the spinal column, and I have some images of those too because they're the most common. There's cauda equina syndrome and conus medullaris, and that's where we have damage to the nerve roots in the lowest portion of the spinal column, and what happens is they have trouble with their lower extremities and bowel and bladder function. And you can have either anterior or posterior cord injuries. That depends on, the front part of the spinal column or the back part is going to be damaged. The two most common incomplete cord injuries are the central cord problem. So this is and the Brown's cord one, but the central nerve one, what happens is that the central gray matter or white matter of the cord gets damaged, and that's most common in our cervical injuries. We then see a mixed problem where we lose motor function of our upper extremities, and it ends up having a narrowing or stenosis, so then we have a mix of sensory loss in the lower. Brown's cord is characterized by one side or hemisphere of the spinal cord gets damaged, so then one half or one side of the body is unfunctional or hemiplegia, so like the right arm and right leg will be damaged and loss of sensation or motor function. This is what happens in the central cord problem. So they lose movement and sensation in their upper arms, like their neck down to their chest and their arms, and then in their lower portion they have a loss of everything, so they just have no movement or sensation down there. Brown's cord is where we have the half or the hemisphere injuries. So on whatever side of the cord is damaged, right, they're going to lose movement on the same side. So if it's on the right side of the cord that's damaged, then they'll lose movement, motor function in their right arm and right leg. On the other side of the body that is not damaged in the cord, they will lose sensation of like pain, temperature control, and things like that. Spinal shock is a complication that happens to people who have spinal cord injuries. About half of all people with a spinal cord injury experience spinal shock. It happens in the immediate... Okay, so this happens in the immediate injury period. It can last for days to months afterwards. It is not the same as neurogenic shock. We will talk about neurogenic shock later. This is spinal shock, so it's a problem where the cord itself is going into shock. You're going to see decreased reflexes, loss of sensation, and then they're going to be floppy or have flaccid paralysis below the level of the injury. Next, we're going to go through each body system and explain how it can be impacted by a spinal cord injury. Alright, so the respiratory system, anything that happens above C4 or cervical level 4. So if we have damage to cervical level 1, 2, or 3, they have complete loss of their respiratory muscles. Alright, that means their diaphragm doesn't work and their rib cage muscles do not work. These people have had significant damage or complete loss of function to their brain stem. They require mechanical ventilation to stay alive. They usually lose all other functions as well. These are most often the folks that are categorized as brain dead. If they have a cervical injury below C4, alright, then they will have diaphragmatic breathing, which means they can initiate some breaths on their own, but they're not going to be fully functional. And if they have lower cervical or thoracic problems, they're going to lose their muscle, their abdominal muscles, but they can still do some breathing on their own. Thermoregulation is the ability of the body to be able to maintain its own temperature. A complication of spinal cord injuries, especially in the immediate period, is that their spinal column cannot send signals through the central nervous system anymore. And that means that your central nervous system cannot signal for the body to cool down or warm up with shivering or sweating. They're at risk for not being able to maintain their own body temperature. So then their body temperature drops to whatever their environment is. Alright, so if your thermostat in the room is set to 75 degrees, if they aren't kept warm with blankets, warmers, heating things like that, their body temperature is going to drop to 75 degrees. The cardiovascular system, anything that is injured above thoracic 6 is going to decrease the sympathetic nervous system. Remember, that also regulates your heart rate. So these patients, we're going to see bradycardia, which is slow heart rate, or possibly asystole, which is no electrical activity of the heart, and they would be dead. Right? They're at risk for peripheral vasodilation, where those blood vessels in their peripheral circulation just dilate and open up. And that's going to make their blood pressure drop, because then we have significantly dropped afterload if everything's vasodilated. Neurogenic shock is a complication of the sympathetic nerve system that is no longer working, right? Because you don't have the spinal cord to regulate the sympathetic nerve system signals anymore. You lose muscle tone of your vessels, right? They become overly dilated, the blood pressure falls, the venous system doesn't return blood back up to the cord, so it just pulls in the peripheral circulation, and patients are at high risk for deep vein thrombosis, which is blood clots in the veins. Most commonly, they happen in the legs and the calf muscles. They're at risk for low blood pressures and decreased cardiac output. We'll see a slow heart rate, and they may even need a pacemaker if it continues for too long. Their extremities are going to be warm from that blood pooling there and dry. This generally happens with a cervical or high neck injury. Patients are also at risk for orthostatic hypotension. So since we don't have normal autonomic nervous system responses anymore, particularly the baroreceptors aren't going to get their signals sent back through the cord, when we sit them up, they're going to have that drop of blood pressure. They're also at risk because of that decreased tone in the peripheral vasculature, where the blood is just pulling in the arms and legs. So that increased risk for deep vein thrombosis. If they change position, they could pass out, especially if it's not done slowly. They may even require the use of like a tilt table to slowly sit them upright, and physical therapy to help. In the peripheral vascular system, they're at risk for those clots. So, and we'll talk more about this whenever we have pulmonary coming up, but what happens is in the leg, since blood is pulling, it will get clots that form. When blood has stasis or stays in one spot too long, right, they're at increased risk of congealing and having clots. The problem is that a lot of times with these DVTs is part of the clots will break off, and they'll travel up through the circulation and lodge themselves in the heart or the lung and cause complications in heart attacks, or have their lungs not be able to exchange air. A DVT actually happens in about 73% of patients who have spinal cord injury, so we really want to work hard to prevent it and to keep them from having complications. In their GI system, if they damage anything above the level of thoracic 5, they're going to experience a slowing of the motility or movement of things through their GI tract. That puts them at increased risk of having ileuses. And remember, we talked about those with bowel obstructions and the GI content. Their abdomens can also have gastric distension, and they're at risk for ulcers and bleedings. In their bowel, they're at increased risk of complications with neurogenic bowel. So you have nerves that conduct signals from the intestines, especially in the rectum and things, up into the spinal cord, and that's what tells people when they need to go to the bathroom, controls their sphincters, things like that. If the bowel is areflexic, which means now the damage of the spinal cord has left no nerve endings going to the bowel or the intestine, then those sensations don't get passed back. So then people with spinal cord injuries don't know whenever they have to use the restroom, right? And the feces and the bowel can just get overinflated and back up and is at risk for rupturing. They can also lose control of their sphincters, so they won't have any tone or will be decreased, so that increases risk for incontinence issues. Similar complications with the bladder. Alright, so you have nerve endings that go from the spinal column to the bladder. If they don't make their way, the signals, because of a spinal cord injury above thoracic 10, right, then they're going to lead to difficulty with the sensations of being able to go to the bathroom. So then urine's just going to remain in the bladder and cause urinary retention. If too much stays in the bladder at one time, the bladder is going to get distended, which is overinflated, and it's going to trigger impulses to the nervous system, which is going to cause problems with the sympathetic nervous system getting overstimulated. To drain the bladder, patients most often need to have Foley catheters or indwelling catheterizations. Sometimes they can be intermittent, where they just do it multiple times a day on a schedule to drain the bladder, and sometimes they have to remain there. The skin system is at increased risk of having breakdown because they're not moving. Alright, if they lay too long in any position, anywhere that their skin is over top of bony prominences, alright, like the shoulders, the heels, the hips, alright, if they don't move, then they're going to not get circulation, and the skin can break down by what's called pressure ulcers. Alright, so the skin will erode away because it's not getting enough circulation. This is why patients who have mobility issues need to be turned every couple of hours. The ulcers take a long time to heal. They can be very deep, like this gentleman's down here. It can go all the way down to the bone through muscle layers, and they're very hard to treat. So our concern is to prevent them, to keep them from happening, and to also keep them from getting infected if they do get them. Autonomic dysreflexia is a complication that can happen to anybody who's had a spinal cord injury above T6, and it can happen anytime throughout their lifetime. So this is very different than neurogenic shock and spinal shock. Right, so even if they have their injury whenever they're 20, when they're 55, they are at risk for autonomic dysreflexia. What happens is that there's something that is stimulating the sympathetic nervous system response, but because of the injury to the spinal cord, those signals never reach the brain to tell the person that they need fixed. So the spinal cord just continues to be triggered, and it continues to activate your sympathetic nervous system, particularly the release of epinephrine. Alright, and if it's not resolved, it's going to impact different systems of the body. Alright, so the lesion's blocking the impulse, so they never reach the brain. Some noxious stimuli is just hitting the spinal cord signals because it's triggering responses. So for instance, things like their clothes are on too tight, below the level of the injury. They have ingrown toenails. They have a bed or pressure ulcer that's causing pain to them, right? They can't feel the problem, right? But it's still triggering a nervous system response. All right, normally your cerebral cortex moderates these, all right? But in this case, it never gets the signal, so we just keep triggering releases of epinephrine. That's going to increase the heart rate and the blood pressure, and if it continues and goes on without treatment, they can be life-threatening and lead to the patient having a stroke or hemorrhage. So this is just an infographic about autonomic dysreflexia. Above the level of the injury, you'll see them having sweating. Alright, they'll be flushed. Below the level, they're going to have vasoconstriction and their extremities will be cool and dry. right? They can be triggered by really anything that's considered annoying, even mildly. So for instance, their shoes are on too tight, their belt's too tight, right? They have a pressure ulcer somewhere, their